Hi, and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we do this podcast every Wednesday for you, the technicians and veterinarians in general practice, to give you insights and actionable steps that make your dentistry service even better. If you have not already, the International Veterinary Dentistry Institute is sponsoring a live seminar, online training, July 17th, and you're invited. Register at ivdi.org/July, and we'll see you there. Kimberly asked, can you please explain vital pulp therapy? And we use vital pulp therapy mainly in cases where there have been super recent fractures that the owner knows that the fracture was at a certain point in time, which almost never is accurate unless they actually see the fracture as it occurs, look at the pulp cavity and see it's bleeding. That's the only time that we would consider historically doing something for saving that tooth without having to go to a root canal extraction. And I think that's a later question that we have. But vital pulp therapy, essentially what it does, it allows us to either reduce the crown when we've got a malocclusion, for instance, a mandibular canine tooth that's impinging upon the palate and digging into the palate, causing a malocclusion, or we have a fresh fracture that's less than 24 hours old, ideally, and uncontaminated, or at the most 48 hours old. After that, the statistical success rate are very poor, so we would essentially do root canals on those if the owner wants to save them, or if in practice, if they don't, that's an extraction. You want to extract that tooth if you're comfortable extracting teeth that have no perio. And that's with a surgical flap, mucoperiosteal flap, and exposure and extraction with using burrs to remove vestibular bone, making grooves, extracting the tooth, contouring the bone with a diamond football burr, and then suturing that close after a radiograph confirms that that tooth has indeed been fully extracted. Back to vital pulp therapy, if that's the indication, based on what I just said, where we're trying to save a tooth and not compromise the pulp, then what we would do would be to get down to healthy pulp in the case of a fracture, or we would do a crown amputation in the case of a malocclusion with a sterile burr under reasonably sterile circumstances, and we'd remove a couple millimeters of the pulp, depending on how big that patient is, maybe less than that, and then that's going to bleed, so we have to control the hemorrhage, and then we place mineral trioxide aggregate, which is a biological cement, literally a cement that you could go into Home Depot and buy a big sack of. That is the same thing. It's just sterile, and they've put it through the sterilizing process, but it's essentially a cement, or they have liquefied it to make it easily applicable, and that's what we use. And then that sits on the pulp and lets that pulp heal, and then that is cured if it's a liquid like we use, or if it's just the actual cement itself or the MTA itself. It's placed on the pulp, and then on top of that we use what's called a glass ionomer generally, or a composite, or both, that seals the restoration, seals the tooth in multiple layers. So that allows that tooth to stay viable, and then we recheck that radiographically every 6 months or so for a couple times. And if in a year it's still, the tooth is growing, the dentin's getting smaller with the growth of that tooth, and everything's fine radiographically, then we've got a successful procedure. Success rate on those, if they're done with a vital pulp with a malocclusion under pretty sterile circumstances are greater than 90%. And if it's within 24 hours, probably close to 90%. So hope that answers your question. And good question. So good way to start off this this group of questions. So Carol Kaluka, is there a time limit where a root canal would not be an option? For instance, a fracture that is a year or older. Great question, Carol. And the answer to that, if there is a fracture that is 5 years old and the changes are not super significant on X-ray where you've got a huge periapical lucency but there's pulp exposure, those can still be saved with a root canal. If the owner doesn't want to opt for a root canal and referral, which is usually the case, you guys are going to find out if you're offering referral for a lot of these things we're talking about today, that most clients are not going to do it. Maybe there's not a referral practice close. Maybe they don't have the funds to do that. Maybe saving that tooth is not the best in their interest justifiably. Maybe it's not a tooth that we'd save. You know, we save canine teeth, maxillary fourth premolars, and mandibular first molars occasionally. But for the most part, that's the ones that we do root canals on. Incisors sometimes, if it's a working dog, maybe a dog that's a special needs dog, or maybe it's a police dog, sheriff's dogs. We do NASA down here in Orlando. We do their bomb sniffing dogs on Cape Canaveral in Cocoa Beach. But that aside, there are times when that wouldn't even play a role. If you're talking about a premolar or the last molar, those are not really functional teeth, so we wouldn't even consider root canals on those. Those are always extractions. We're not going to do a root canal on a premolar tooth that's not a fourth upper premolar. It just doesn't make sense. Those teeth are not functional. They don't occlude. They don't chew teeth or chew food. They might chew teeth if there's a malocclusion, but they don't chew food. That's done in the back part of the mouth for the most part. So we wouldn't consider those. So Carol, hope that answers your question. Very good question there from that respect. And from Allison, once a crown is placed, how long do we expect that to last for the patient, and will it eventually need to be replaced? And I'll make this a short answer to a very short question. And the answer is you expect that for the lifetime of the patient if it's done correctly. So if we're doing it, and in our track record we've had one of those come off, maybe two with a really short crown that doesn't have a lot of crown surface that we're trying to preserve, but after thousands upon thousands of crowns that we've placed over the last 20 years plus, they just don't come off. We use a cement that is very tenacious, and so that was actually longer than I expected to answer, but they don't come off. So Kathleen, what's the success rate for vital pulp? Kathleen, I answered that already, but we do have a couple of studies that show more specifically. This was done, a study was done back in 2001, and the percentages for these were all done 36-month post-op, 88%, 40%, and 23% at 48 hours, 1 week, and 3 weeks. So you can see with a week you drop down from over 90% within 48 hours, and then it grows exponentially bad from there. So we don't recommend that at all. We're gonna recommend extraction or root canal, and not vital pulp therapy. And then more recently, Dr. Verstrata and his colleagues, Dr. Verstrata's at UC Davis, and done a lot of research over there on a lot of things veterinary medicine, more recent perspective look at cases, and looks like in their success rate was 92% for the cases that were controlled. And I haven't recently read back in this study, but that's using MTA and probably within that 48-hour window. So great question there. Thanks for that, Kathleen. So can we provide general guidelines for when to refer to a specialist for root canal, the time frame, the characteristics, the radiographs? And we've touched on this a little bit, Katie. This question comes from Katie Holly, and we've touched on that a little bit, but let's look more specifically about time frame. So time frame we've talked about doesn't matter for the most part, unless we're doing vital pulp less than 48 hours. The characteristics of the fracture, if there's pulp exposure, we definitely want to refer if there's radiographic evidence of increased pulp diameter compared to adjacent teeth or the same tooth on the same jaw on the other side, then that is an indication. If that tooth is fractured has a larger pulp chamber diameter, that means the dentins stop growing and the pulp cavities stop getting smaller with dentin growth. That means the tooth is dead, and so that would be an indication radiographically. And then also the other indication would be if there's a periapical lucency. So that's when you have an option to refer for root canals. So nice question, Holly, Katie. And what classes are available to learn root canals? Short answer to that, there are none. The AVDC prohibits veterinary dentists from teaching root canal therapy to general practitioners. The learning curve is way too high, and I used to tell people 10 years ago, 12 years ago, whatever it may be, 15 years ago, that I've been doing root canals after becoming a specialist for 10 years, and I think I'm just now getting good. And so that kind of puts perspective into how difficult these things are from a decision-making standpoint. So we don't teach these. They used to at the dental forum. They don't anymore because they realize that that's not the thing to do. You don't see enough. You don't have enough practice. And enough practice is probably 5,000 to 10,000 hours of practice to get really good at these where you can do them and do them quickly and efficiently. So not something that you'll do in practice, not something that you're willing, unless you're specializing, to put the time into to make it happen so that you're good and you're providing a good value to the patient. So Anisha, how do you convince or explain to clients the need or importance of extracting devitalized teeth, or ones that are just partially extracted and the owner perceives the dog not to be in pain and they are acting normally? So that's a great question, and that comes up a lot in our courses. So client education, this is one really good example that takes all those things that you talked about and puts it into one good example. You've got a tooth that may be slightly discolored. There's no crown impingement. There's no changes in that tooth that are visible other than the color change. Or you have a tooth that has a lucency radiographically but looks perfectly normal with no color change. So those two situations may be difficult to explain to the client without having good images. So if you've got the Veterinary Dental Image Library, which a lot of you have, I think when you registered for this workshop you had an opportunity to get that. I think it's $17 or something like that to get it. It's got a lot of images that you can use for client education. And Sonali, if you're in the chat, put that in there, the image library link, and they can do that, or search for Veterinary Dentistry Image Library in my name. You'll be able to find that. You can get that as a PDF. You can put that on your computer and use that for all client education. You can show them a lucency on a tooth and let them know that that tooth was what happens when these teeth that are discolored are allowed to go for any length of time. If you don't have that patient where you've got the radiograph of the tooth that's not discolored already. So that would be for a discolored tooth in the exam room. Show them what that progresses to in most instances, even if there's no pulp exposure. That discolored tooth is discolored because the pulp is dead or dying. When that pulp dies, it releases toxins and metabolites that destroy the bone around the tooth apex that result in that lucency. So it doesn't have to have infection associated with it. It's just those toxic metabolites of pulp necrosis that cause the inflammatory condition that results in the periapical loss of the bone. So if that's the case, then you're gonna not have a radiograph if you're talking about this in an exam room. So that's where images that have been taken previously come in handy. If you've got the radiograph and the client has declined extraction or root canal because they don't believe it's a problem, then you show it to them at discharge and let them know this is a hole in the bone that's created because the pulp's dead. That hole is not going to stay stable. It's going to get worse. It may cause a fistula eventually, although it takes years for that to develop. And in the meantime, that patient is suffering silently because that is uncomfortable, if not painful, with that bone destruction and inflammation that's going on. So hopefully that answers your question. Certainly it covers that whole scope, I hope. And then Christiane, what can I advise my clients who are interested in referral for a potential root canal as what to expect as far as monitoring goes for the lifetime of the animal? That's another real practical question from a potential referral, from a general practice potential referral standpoint, which should come up a lot now that you guys are well versed in what the potential for root canals would be versus not root canals. So what do we tell the client's going to be involved with that? So number one, if you're coming to my practice, we're going to put a crown on that tooth, and then unless that patient's older and doesn't have an expectancy of 5 years to still be with us. So we're going to put a crown on that to protect that, because we know that micro leakage happens around any composite restoration and can start and generally does in humans around 5 years after that restoration is placed if it's not covered with a crown. So we're going to put a crown on there. So that's a 2-visit thing. So if your dentist that you're referring to places crowns, which a lot of them do, some of them don't, then that is going to be a 2-visit procedure where we do the root canal, we do the preparation for the crown with burrs, and then we make an impression, send that off to the lab, and then in 2 weeks we get the patient back. So there's going to be that recheck. And then when we get a patient back, or when you get a patient back for a routine cleaning in a year, 18 months, 6 months, whatever it may be, depending on the patient and their periodontal status, we recheck the radiograph. And in our case, we've got pretty much, I would say, 98% of the ones we follow up are going to work. There's very few that we've ever had to extract or do surgical root canals on over the years. So depends on what you look at. 92%, 93% is what the literature suggests. So there's a real good possibility there's not going to be any problems or follow-up going forward except for routine radiographs. So that should answer your question. If there is a failure, which happens by some measure, then that's either redo the root canal, surgical root canal, which is a whole nother ballgame and conversation, or an extraction on your end, or the referring vet or the referring dentist or the dentist that you refer to would be doing that. And if that's coming in to most practices, it's down the road a bit, where it's had time to develop over time, and there may be root dissolution in conjunction with that, and so extraction is usually what ends up happening with those. If tertiary dentin's present at the site of a fractured crown, no lucency present on radiographs, do you need to extract? So the question is, it all depends on the radiographs. If that has been sealed and it actually sealed off with tertiary dentin, but the changes had already happened deeper and the bacteria had gotten in there, or that tooth was compromised from a pulp standpoint and the trauma itself killed the tooth, then there's no reason to extract, and there's probably no reason to really follow that up, because the tertiary dentin has already come in there and healed that. And if there's no radiographic changes after that month or multiple months that it's taken for that to happen, then there's a chance that they won't. Most of the tertiary dentin we find is generalized with wear that's happened in younger patients over time, that the owners have stopped the wear behavior, just as an aside. So if there's no changes that would suggest that's a non-vital tooth, you do not need to extract. You don't want to extract. Go down to Megan's question: what is your recommendation for a puppy who comes in with a fractured deciduous tooth? And the answer to that is extraction, and extraction that day if possible, because that pulp's exposed. That pulp is huge, and it's going to get infected if it's not already. The puppy may or may not show that it's uncomfortable, because they're puppies. They're 90 to nothing all the time. Nothing seems to bother them for the most part. And any things that they do, like rubbing their face on the ground or rubbing that side of the face, maybe just be perceived as puppy behavior. You know, they're active anyway. And so it's not really picked up if they're uncomfortable. And those things can abscess, and often do, and they go undetected, and the dog suffers until the body takes care of that and eventually resolves it after weeks. So always extract those, and always get pre-op radiographs to make sure you're getting all the tooth root, because some of those might be partially resorbed. And a lot of them will have apical to the mucogingival junction, or at the mucogingival junction, they'll have a fistula. You can actually see that fistula, but not always. That's when it breaks through the bone and affects the tissue. So yes, you want to extract those. So thanks for listening to this episode. We'll see you next week. And if you haven't already, please register for that free live new training July 17th. We're expecting around 600 to 1,000 people to be there live on that date. So don't miss out. IVDI/July will get you into that course. And we'll see you guys next week. Take care.